Welcome back to Cancer Buzz. I'm your host, Summer Johnson. In this mini episode, the final installment of our three-part series on the role of the advanced practitioner in equitable cancer care delivery. The majority of U.S. cancer practices report that they employ advanced practitioners, but they might not be used to the full scope of their abilities in the area of clinical research. This spring, ACCC and Harborside together hosted a virtual summit where oncology nurse practitioners, physician assistants, pharmacists, oncologists, and patient advocates convened to determine how to better engage advanced practitioners to advance equitable cancer care delivery. Our guest today helped organize the summit. Dr. Beth Faiman is a nurse practitioner at the Cleveland Clinic in Ohio. We asked her to share the evolution of the advanced practitioner role at her cancer center, where they work to the top of their licensure.
At my institution, I work primarily in some solid tumors as well as multiple myeloma plasma cell disorders. At our institution, we are encouraged to work at the top of our practice scope. So in Ohio, we can adapt an oncology care model that uses physicians, advanced practice providers, nurses, social workers, and really bringing all those team members into the team. On a regular clinic day, maybe 50% of my scheduled patients are there for routine monitoring. And really, we try to determine if treatment is safe and appropriate. We sign orders, authorize continued treatment, et cetera. And of course, manage any side effects to keep them on the appropriate therapy to control their cancer.
Walk us through the process of how advanced practitioners engage in those discussions on trial protocol, review, feasibility, staffing, that sort of thing.
So one of my goals throughout my nurse practitioner career was to learn more about clinical research. So I was fortunate to obtain a PhD in research a few years ago to better understand the research process, the statistical methods, and initiate independent projects. So at my institution, I feel fortunate that my disease team and my colleagues realize my level of knowledge. And so I am on the table whenever we have a new research study, a protocol gets sent out. We look at the scientific rigor, methodology, and we also see the burden and take into consideration the burden to the patient and the nurses and the study participants as well. So we want to advocate for our research staff, and that's something that APPs do at our institution quite regularly.
Who or what team has been instrumental in making this work at your center? Is it advocacy from the advanced practitioners, or has there been physician champions, or has it been backing from the administration?
That is an excellent question. I think throughout the years of clinical research and the department that we've built at my institution, I feel fortunate to have physician support and administrator support. My physician colleagues have championed to allow advanced practice providers to, again, practice at the top of their scope. And so it wasn't just one person, but I started advocating for myself and my colleagues to have a larger voice in clinical trial participation. And I think by screening for clinical studies, increasing our knowledge so that we know about the research studies that are coming in, the drugs that are being tested, et cetera, and then working together as a team to promote best practices. I think it's really been a group effort. But yes, I think the physician champions and our APP colleagues have all worked nicely together in a collaborative way.
Have you found that having advanced practitioners involved in clinical studies right from the beginning streamlines or impacts the overall workflow?
Well, one of the things that we strive to do as advanced practice providers is set rapport with patients. We see them on a regular basis at many cases, and so maybe they're not on a clinical trial, but we're oftentimes, with our knowledge of the clinical trials available to them, perhaps at relapse or if a therapy isn't working, screening is really important. And that's integral for APPs in that screening and clinical trial participation. So not only that, the appropriate monitoring of the disease is really important as well. You know, we're monitoring the patient process. We're seeing the patients and their caregivers in clinic on a monthly basis. So there's oftentimes an opportunity for clinical trial participation. Just to segue, I wanted to bring another point that I've recognized in the last few years And that's of implicit and explicit bias. Many times as providers and physicians and my colleagues, we might have this implicit bias where we have these attitudes towards people or associate stereotypes that are incorrect, or explicit bias when we have attitudes towards people without our conscious knowledge. And so sometimes I wouldn't offer clinical trials to my patients because I think, they're not going to want to drive an hour each way for this clinical study. But recognizing the biases in research, whether we know it or not, and then just offering clinical trials to everybody has really helped improve our accrual, I think, in many cases in my institution. And using our team members, like the social workers and financial counselors, to gather support for that transportation back and forth, or maybe even housing overnight, so that they can have access to these clinical trials. And finally, I like to wear a pin that says, ask me about clinical trials or other appropriate clinical research studies. So it's just out there and they don't have to think about it. They might bring it up to me.
That's a great tip. I don't think anyone has said that before on Cancer Buzz. What do you think is missing in the current healthcare landscape that would support greater APP involvement?
That's an excellent question. And unfortunately, I think it goes down to resources. I know we are all COVID-19 pandemiced out right now, but this last year pandemic, we had in many institutions, larger, small, community, et cetera, had been moving forward, I think, in identifying appropriate clinical trial participants and then offering those trials. Also, these trials were put on hold during the pandemic. We lost staffing, nurses, doctors, et cetera, people retired. And so the lack of staffing. So it's going to be more resources moving forward, more personnel, research studies staff, as well as the financial backing, the grant funding for a lot of these studies that is lacking right now because of the pandemic. So hopefully our discussion, if we have it in 5 years, might look totally different from the discussion today. But again, lack of time in the clinic and lack of financial and physical resources needs to be addressed.
You can find more from the ACCC and Harborside Summits on the ACCC website at ACCC-Cancer.org. If you've been enjoying this Cancer Buzz audio podcast, be sure to give it a follow and check out the brand new Cancer Buzz TV channel. Just search for Cancer Buzz TV on Apple Podcasts. Until then, for the Cancer Buzz team, this is Summer Johnson.
Cancer Buzz is a resource of the Association of Community Cancer Centers.